Good evening, friends. Am I audible? Am I audible? Should I start? Good evening, friends. First of all, sorry for this last minute change, but I have some emergencies, means some commitment I have to follow at 7:30, so I have to immediately prepone this lecture slightly earlier. And if you needed, I can provide you a recording because I know this is a very busy time for the most of the practitioner. Either they are a family physician or they are family physician or they are doctors or what we call resident doctors. But this evening time is very busy. So I know the audience may be less or even zero, but it is my duty to complete this series, and we will provide you recording if required. Okay, so today our topic is stepwise management of ascites. So basically, for the resident doctor, first thing I want to know is that ascites doesn't mean cirrhosis. There are other causes of ascites, but in this particular talk, we are dealing with the cirrhotic ascites. And why? Because most of the cases you are seeing is the cirrhotic ascites. And in the next one slide, we will see the one study on the SAAG, which is in the study done one it was done in the 1992. But till out of 768 patients, only 42 patients has a non-cirrhotic cause of ascites. So, but till despite of this such a low number of non-cirrhotic ascites, this study still hold the test of time for the SAAG interpretation in the ascites. There are no maths in medical science, but ascites fluid analysis is a little bit of particularly the analysis of SAAG is, I think, you will reach up to the diagnosis by 80 or 90% if you interpret the SAAG and ascitic fluid analysis properly. So now we are going to start with the ascites, but this particular talk we will restrict it to the cirrhotic ascites. So once there is a cirrhosis, you know there is a fibrosis, there is an increase in the hepatic sinusoidal pressure that lead to the portal hypertension, and there is also endothelial dysfunction, splenic vasodilatation that lead to the activation of renin-angiotensin mechanism, and that lead to the sodium and water retention, and finally the ascites. This is the same cirrhosis. Don't go into the detail what is PAMS and NAMS, but this is the some precipitating factor due to the bacterial translocation and liver injury, few cytokines which lead to the systemic inflammation and lead to the splenic arterial vasodilatation. So effective arterial blood volume has been reduced that lead to the renin-angiotensin mechanism activation that lead to the sodium retention, ascites, sodium free water retention, then there is a dilutional hyponatremia, and as a result of splenic vasodilatation, to maintain the renal perfusion, there is a renal vasoconstriction. But when this vasoconstriction exceeds above certain limit, it compromises the renal flow and that lead to the hepatorenal syndrome. So all of these are seen in different proportion in different patients depending on the pathophysiology. But basic pathophysiology is the splenic arterial vasodilatation, but lots of the cytokines are playing a role in this. So most of the drugs which are using for the ascites, dilutional hyponatremia or a hepatorenal syndrome, the basic mechanism is to reduce the splenic arterial vasodilatation or make it vasoconstrict. So this is the epidemiology of ascites. It occurs in the 50% of the patients over the 10 years. The mortality is approximately 40% at 1 year and 50% at 2 years. Now, this figure is somewhat higher if you decide or if you see in your patient population. Now, suppose some patient with the cirrhosis comes with the new onset ascites. It doesn't mean that they are going to die in 40% at the end of 1 year. You have to rule out the cause of ascites, because sometimes then child A status, because of some acute insult, converted into the child B, and if that insult has been properly taken care of, and underlying liver etiology for cirrhosis is somewhat favorable, then again that patient comes into the what you call the child A status, and ascites may be resolved. But when patients come with the ascites, so when you predict there is a poor chances that this patient will survive long, this patient having a hyponatremia, particularly sodium less than 125, having a low systemic arterial pressure, increased serum creatinine, and low urinary sodium. So when you patient with the cirrhosis and ascites comes to you, as usual, as a resident doctor or as a physician, you are taking a history examination. You will go for the routine CBC, liver biochemistry, and investigation to rule out the other systemic causes. So the first question: when to do TAP? Suppose one patient is a non-cirrhotics with ascites, comes to you after 1 month with some problem. Should we tap every time? So, any cirrhotic with the new onset ascites should be tapped according to the EASL. And if patient with ascites having hospitalization or any complication of cirrhosis like oliguria or hepatic encephalopathy or a kidney injury, then you have to go for TAP. The hospitalization and complication of cirrhosis is indicated by ASLD, while all three has been indicated by the EASL guideline. You may also consider the oliguria, fever if no other cause has been found, loss of response to the diuretics without any particular reason despite of the salt compliance, abdomen is disproportionately warm, abdominal pain or tenderness, unexplained worsening of the LFT in a cirrhotic, or unexplained diarrhea in a cirrhotic, because this is also a presentation of spontaneous bacterial peritonitis, and diagnostic ascitic fluid analysis is very important. So what are the sites of the tapping? This is for the resident. So usually in our conventional teaching, you used to do it in the right iliac fossa, two finger breath means around 2 to 3 centimeters cephaloid and medial to the anterior superior iliac spine. However, you can do it in the midline and the left lower quadrant. However, the left lower quadrant is the preferred space here. Uh, can you see my marker? Nene, can you see? So left lower quadrant. So whatever. So left lower quadrant is the preferred space for the tapping, and you can go it in the midline also. The midline is relatively avascular, and there is always a chance of collateral. But when there is ascitic fluid is low, you can make the patient sitting position, empty their bladder, ask the patient to pass the urine before that, and you can try tapping here. In left lower quadrant, it is very thin, easy to puncture, as well as easy to with minimal risk of bleeding or complication. But when patient is constipated and sigmoid colon is grossly distended, you may lead to the inadvertent colonic perforation. The right iliac fossa usually we tap, but in patient with the distended cecum, particularly when patient is on the lactulose, chances of perforation is there. And there may be a past history of right iliac fossa scar because of appendicectomy or some other reason, then it may impair your tapping attempt. So preferred site is the left lower quadrant, but if you are not comfortable with it, you can go with conventional method. Now, once you sand fluid, for this is the first is very important. Sand into the plain as well as EDTA bulb, and uh, both counts should match. When you send it in the plain bulb for the total count placement calculation, so there may be a difference in the EDT and plain calculation. So Your whole judgment about the SBP or tuberculous ascites may be deteriorated. So send it in the both plain as well as editable. Bedside inoculation to the blood culture is a necessity, and at least 15 to 20 ml. Most of the blood culture bottle can accommodate. So at least 15 to 20 ml of the ascitic fluid should inoculate into the bottle. It is cell count, total count, differential count, protein, and the albumin. Now, what happens when you write a ascitic fluid routine and the micro? Usually, that lab doesn't give you albumin. While it's an essential part, without albumin, it is very unlikely that you can interpret the SAAG. And SAAG is much more accurate in the ascites rather than pure transudative and exudative method. If you required a severe pyogenic bacteria or something like that, you go for the LDH, sugar. When you go for the ADA, when you suspected the mixed ascites or a tuberculous ascites. However, ADA value is not very sensitive and specific in the mixed ascites, but still you can take your chance. And if your suspicions of tuberculous ascites, imaging suggests to a peritoneal thickening, and ADS is high, you can safely start AKT even in the patient with the cirrhosis. For malignant cell cytology, quantity is very important. At least you should send 500 ml, if possible, 1 liter of the ascitic fluid for the better outcome. Ascitic fluid MLS to rule out the pancreatic ascites, and its cutoff should be more than 2000. Ascitic fluid triglyceride is for the chylous ascites, and cutoff should be more than 200. So coagulopathy correction prior to the tapping. Now this is very important. Sometimes say a patient is INR of 3, should we transfuse FFP or tap or not? So by a rule, coagulopathy correction is not required before a diagnostic or therapeutic paracentesis, but when you prefer is when there is a clinical coagulopathy. Suppose patient's sisters told you, sir, when we used to keep this patient a blood sample, there is a small amount of oozing every time going on from the hand or limb, or there is a blue patches or ecchymosis over the skin you can see. Then, irrespective of the INR, there is a risk of bleed, and you should correct the what we call the coagulopathy. If patient has underlying low DIC or fibrinolysis, tag is useful. However, it is very expensive and not available easily. Renal dysfunction, INR more than 2.5 and platelet below 30, and the sepsis. Now, INR and sepsis, this may be you have to remain cautious. It doesn't mean that you have to transfuse and then you have to do, but chances of bleeding may be there. Or will you go it by USG guided versus clinical? So USG guided tapping is not in the guideline unless and until fluid is low and you want to tap, or a fluid is loculated. Fluid is loculated, then and then USG guided tapping is required. As far as the bleed is concerned, it doesn't matter either you do a USG guided as well clinical. Even most of the paper supporting the clinical tapping for the routine purpose, because most of the bleed occurs when ascitic fluid paracentesis happens is from the small collaterals, and that even missed by the USG guided tapping. So, if you have a doubt that the ascites is not able to tap, let's say relatively less in amount, grade 1 ascites or a loculated or separate ascites, go USG guided tapping, but it is a gross ascites, no requirement for that. Now, once you trap the ascites, you may have a clear cloudy ascites. So when there is a usually it is a clear. When there is a cloudy, neutrophil is the culprit. When it is a red, it may be a clotted versus non-clotted. It is a traumatic versus hemorrhagic ascites. Suppose what happens? The RBC comes into the ascitic fluid either from your needle trauma or pre-existing hemorrhagic ascites. So how will you differentiate? You keep that sample and see if that the hemorrhagic sample is clotted or not over a period of time. If it is going to become clotted blood, then it is a traumatic ascites. But if it is remains because it is a remains lysed blood in the hemorrhagic ascites, it will not be clotted. So it is not going to clot means. If it is opaque or milky white, then high triglyceride level, you can say it may be a chylous ascites. You may see in the hypertriglyceridemia patient when develop sometimes ascites, particularly uh, you may see this type of milky white, pigmented or jet plaque. It may be a malignant melanoma, pancreatic necrosis, or whole blood. But more important, rather than the gross appearance, is the ascitic fluid albumin gradient. The ascitic fluid albumin gradient is the very good to differentiate diagnosis of the ascites. This paper is from the 1992, but till it holds their fact. So if SAAG is more than equal to 1.1, then you are dealing with the portal hypertension, and it is superior to the transudate and exudate consent. Only few cases such as the cardiac ascites having a high SAAG despite of the high protein, and mixed edema having a high SAAG. Otherwise, if there is a high SAAG, usually you are dealing with the cirrhosis and portal hypertension. Now, there is a terminology. Only grade 1 ascites means only detectable by USG. Grade 2, moderate and symmetrical distension of abdomen. Grade 3 is the severe abdominal distension, and grade 4 minor TANS ascites. So it is what is the TANS ascites? Either it lead to the respiratory compromise, or you are not able to indent your finger. It lead to the TANS ascites. Now, what is a refractory ascites? Now, you see, in practice, we are easily labeled that this ascites is refractory, but it occurs only in the 10% of the cirrhotic patient. So, median survival, once you label this patient as a refractory ascites, the median survival of this patient is approximately 6 months. Mortality is 70% within 1 year. So, it is you should be very careful before diagnose this as a refractory ascites. So, what is refractory? Patient should comply to the salt restricted diet, failure to lose a weight at least 1.5 kg per week, despite of salt compliance, spironolactone C at a dose 4 milligram per day, and furosemide 160 milligram per day. So usually we use a lesilectone. It is a combination of 20 by 50. Okay. And if you are using a ditor plus, ditor is a torsemide, which is more potent than the furosemide. So you use a 5 by 50. Okay. So dose is very important. So uh, if despite of all this patient is failed to lose a weight, and very important is salt compliance, then you are dealing with the diuretic resistant ascites. What is a diuretic intractable ascites? You are not able to maximize your dose of diuretic because of side effects such as the orthostatic hypotension, hyponatremia, or a severe cramps. Then it is considered as a diuretic intractable ascites. Okay, so how will you manage such a type of ascites? So we just write a salt restricted diet. What do you mean by the salt restricted diet? According to the American guideline, it is just around 2 gram per day. It is a salt restriction, and if you are taking a home meal, home cooked meal, it is equal to no added salt diet. But you should eat cooked at home without any pre-packed food. But this is a European and American concept. In India, average salt intake is around 10 gram per day, with regional variability, with few area of the Maharashtra is a salt intake of 30 gram per day. So for India, you need to be very cautious because our salt intake is relatively high. So you should ask the patient to use a salt sachet. Okay, there is a pre-salt sachet available in the market. You can ask them. So 1 gram or 2 gram salt sachet is available. It may be a strict salt restriction, means no salt at all, lead to the better ascites control. But there is a issue of palatability. and overall reduction of intake and lead to the decrease in the nutrition. If you can use this type of salt-free diet in a obese patient, NASH-related cirrhosis, when initial stage malnutrition is not a very much of concern, and fluid overload needs to be controlled fast. Another mistake we used to do is we advise the patient for the water restriction in the ascites. Okay, water restriction is only required when patient sodium is less than 120. Otherwise, it is not recommended in the management of the ascites because it is against the pathophysiology. Pathophysiology of cardiac failure and ascites is different. So, water logging for the cardiac failure, the person with the ejection fraction of 15% and ascites, and normal heart function with ascites, water restriction guidelines should be different. Now, which common salt product you should avoid? In our Gujarat, it is very common Sindhu Mithu. It is a black salt or rock salt we should avoid. Pickle, Sindha Mitha, black salt, rock salt, pickle, any bakery product, any sauce, any item with the preservative because most of the preservative contains sodium. Seafood, especially prawns and shrimps. Packet products, soup, hams, cheese, juice, fish, poultry. Bakery product, pasta, hummus, effervescent tablet like Ecosprin, and dry fruit powder just like a amchur or something like that is a high content of the salt, and you should definitely avoid it. As such, average Indian salt intake is high. So, which is the preferred diuretics? The best diuretics is aldosterone because it affects the renin-angiotensin mechanism. However, our Indian patient is very much impatient because aldosterone take around 3 to 4 days to act. So usually patient remains one thing, patient required a rapid result. Second, when patient is cirrhotic, okay, they used to what we call it, take out most of the juices. In our Indian mentality, if the patient is sick because of any reason, only treatment is juices. Okay, so they go with the Mosambi juice, they go with the any hemoglobin is low, any red juice like beetroot juice and something like that, pomegranate juice, and all these are high in potassium, and spironolactone itself is causing the hyperkalemia, so it may be difficult. So usually we start simultaneously loop diuretic furosemide, so it will be helpful to reduce the hyperkalemia as well as it gives the rapid result to the patient. So alternative approach is if patient is very cooperative and you are very lucky, you just start with the spironolactone, and if everything goes smooth, you can later on add loop diuretics as and when required. And simultaneously on OPD basis, you can increase this dosage and maintain this dosage every 3 to 5 days if weight loss and natriuresis are inadequate. So how will you assess the response to the diuretics on the OPD basis and the IPD basis? In OPD basis, you call it once a week with weight record, urine output record, as well as electrolyte and creatinine. And check the symptoms for fatigue, cramps, precipitation of hepatic encephalopathy, and at the time of arrival, blood pressure and orthostatic hypotension. Okay, and if patient is in in-house setting for the severe ascites, then you can start diuretics and see the weight loss. It should be half kg for patient without edema and 1 kg for the patient with edema. But greater weight loss is expected in the severe anasarca or massive edema feet. So no need to worry in the initial phase, but you have to adjust the dose every 2 to 3 days. And once, despite of the massive edema has been reduced and weight loss is similar around 2 kg, then you can decrease the diuretic dose also. And you have to check the creatinine and electrolytes every other day in indoor patient because they are more frail patient. When to reduce the dose of diuretics? Once there is no ascites, you can obviously reduce. There is a reduction of the edema feet, then you can start reducing. If there is a too much weight loss, despite of the complete resolving the feet edema feet, but there is weight loss is going on more than 0.5 kg without edema feet, then you should reduce the dose of diuretics. or a side effect of diuretics in form of the increase in creatinine or postural hypotension, hypokalemia or hyperkalemia. When to stop diuretics? Now this is very important. When patient develop a complication of portal hypertension, ascites like SBP, hepatic encephalopathy, having a hypotension, kidney injury, creatinine rise more than 4.3, sudden drop in urine output, or any GI bleed and hyponatremia, you should stop a diuretics. Even patient is under program of large volume paracentesis, you should avoid diuretics on the day of paracentesis. Now, the other diuretics which we can use is this is a paper published before I think 2.5 decades, and the comparison with the amiloride and the potassium canrencate, it is the same like aldactone or a spironolactone, but amiloride is less potent and it requires renin-angiotensin mechanism to be normal to reduce the ascites, so it is not very useful compared to the spironolactone, but it is still used in patients who develop the spironolactone-induced gynecomastia and mastia. And second drug is the eplerenone, easily available. Many nephrologists and cardiologists are using this, but you have to reduce the dose by half because it is a twice potent than aldactone. So if aldactone you are giving a 200 milligram, you have to use eplerenone 100 milligram, and actual effect for the eplerenone it may take around 2 to 3 months to see the actual effect of eplerenone, but it is useful in the aldactone-induced gynecomastia, painful gynecomastia. Non-selective beta blocker, this is a new concept coming since last 2-3 years or 4 years, I say. And severe ascites in patient with the severe and refractory ascites, it should be discontinued. What is the reason? Because non-selective beta blocker also lead to the decrease in the blood pressure, so they will may precipitate the kidney injury and increases the renin-angiotensin system activation, so it increases the hyponatremia. Sometimes during SBP, this circulatory dysfunction is even more worsened, so non-selective beta blocker should be avoided during the SBP when systolic arterial pressure is less than 90, hyponatremia less than 125 in the presence of kidney injury and bradycardia obvious. So by this mechanism, by reducing the arterial hypertension blood pressure, it risks of the hepatorenal syndrome and death in patient with the cirrhosis and the spontaneous bacterial peritonitis. And this is the transplant-free survival rate, the patient without SBP, with SBP, and on beta blockers. So if you see the patient with the SBP on non-selective beta blocker has a poor survival, so when patient develop the SBP, beta blocker should be immediately discontinued. Now again, can we use IV furosemide? Because many of our nephrologist friend as well as intensivist is very enthusiastic about the IV furosemide, but IV furosemide has a detrimental effect in the renal hemodynamics in the cirrhotic patient and should be avoided unless and until it is very needed, particularly when you are confused that it is a pure hepatorenal syndrome or kidney injury, or it is an underlying CKD, or you are under the there is a last paper published by Dr. Virendra Singh that you give the continuous intravenous furosemide along with the continuous albumin and midodrine and terlipressin to improve the ascites. So you see the effect of the intravenous furosemide on the renal clearance. In this, there is a group 2, group 1 is control, and group 2 and group 3 is the cirrhosis without ascites and with ascites. And if you see that the renal perfusion is creatinine clearance, means glomerular function is significantly reduced, and it takes time to recover when you use intravenous furosemide. Now, this is a beautiful study published in the Lancet. Long-term intermittent administration of albumin in the decompensated cirrhosis. If your patient is affording, you should strongly recommend that. And if your patient is in the transplant list, you should strongly recommend that the albumin should be administered intermittently, and it will help to improve the transplant-free survival, as well as it will help to in the waiting period for the transplant. There is a reduction of the need for the tips, for the ascites, as well as if you see the overall detailed paper, there is also risk of the infection has been reduced, risk of the SBP has been reduced. So if patient is affording intermittent albumin administration, particularly in the child C patient, we strongly recommend. Now, how to manage a refractory ascites? So first of all, labeled as a refractory, as we have discussed, confirm the salt compliance first. Then check the dose of diuretic, you reach a maximum or not. For salt compliance, if urinary sodium potassium ratio is high and despite means diuretic is effective, but despite patient is gaining weight, then there is a chance that the patient is non-compliant with the salt. When there is a hypovolemia, the postural hypotension, uh, and there is some other tissue, vascular issue, just like portal vein thrombosis, hepatic vein thrombosis, or some fistula development. Some drugs which increase the portal hypertension, like methotrexate, there may be associated alcoholic cardiomyopathy or cirrhotic cardiomyopathy that lead to the poor ejection fraction and added a cardiac factor for the ascites. Beta blocker, as I already told, it decreases the systemic arterial pressure and more lead to the splenic vasodilatation, activation of renin-angiotensin system. You should rule out the infection like tuberculosis, SBP, or any other infection, because it is lead to the decrease in the whatever liver function we have, and it increases the splenic vasodilatation due to the cytokines. So this is a transient effect, and when you control the infection, it may be possible the refractory ascites will become a responsive ascites after eradication of infection. Large volume paracentesis, this is usually be done because our patients are not affording for the tips or transplants. So periodically we do large volume paracentesis, and by definition it should be more than 5 liter in the single setting. Immediately release the ascites, but chances of recurrence is very very high, and it associated with paracentesis induced circulatory dysfunction. So you should always give albumin after tapping when you go for the large volume paracentesis. So if you see the large volume paracentesis, how it lead to the circulatory dysfunction, it decreases the intra-abdominal pressure, it decreases the mean arterial pressure, that will lead to the hypovolemia, and it lead to the renin-angiotensin activation. Because it is a hypovolemia, we know it is there is a lead to the activation of RAS. Okay, it increases the cardiac output. So cardiac increase the ANP, arterial natriuretic peptide, that lead to the vasodilatation, and again it lead to the hypovolemia, and renin-angiotensin system is activated. So usually you have to give, to reduce this hypovolemia, you have to give intravenous albumin along with the tapping. So when you do it without intravenous albumin, you see there is a group 1 and group 2, and the group 2 is the paracentesis without intravenous albumin, has a significant side effects like hyponatremia and the renal impairment, as well as the hyponatremia means hyponatremia, renal impairment, or both. So always give albumin. Initially it was the you have to give one albumin at the 6 liter, but now it is a 2.5 liter tap. It should be given after the tapping, and it should avoid the diuretics on the day of the tapping, avoid beta blocker on the day of the tapping, avoid tapping more than 5 to 6 liter in a single setting, and midodrine was found to be equally effective in one study only, rather than giving the albumin. If patient is a till refractory ascites and if affording, you should consider tips prior to the repeated LVP. So when to consider tips, but if required a 4 to 5 large volume paracentesis, despite of all your checklist has been corrected, and it decompresses the hepatic sinusoids, it reduces the ascites, but there are few hemodynamic changes that may lead to the slight increase in the renal function and slight increase in the survival compared to the patient with the LVP, and ideally TIPS should be used as a bridge to the liver transplantation. So indication and contraindication for the TIPS for the refractory ascites, we are more concerned about the contraindication when CTP score is more than 13 or more than 20. Male, it is absolutely contraindication. Everyone know heart failure, pulmonary hypertension, particularly right-sided heart failure, is a contraindication. When there is an anatomical or technical contraindication like portal vein thrombosis or hepatic vein thrombosis, you have to alternate the consider like DIPS or something like that. there is undiluted biliary obstruction and obviously extensive hepatic malignancy. If you see how the tips is going on, so effect of the tips on the creatinine. So when at the age of at the in properly selected patient for the refractory ascites, after 4 to 6 months of tips, it decrease the creatinine and increase the survival. And few has a doubt, yeah, post tips transplant will be difficult, but it is not so. If tip stent is properly selected, proper length, neither too in the hepatic vein or IVC towards the right atrium, or not too in the extra hepatic portion of the portal vein, then there is a no technical feasibility. In fact, study says that the TIPS patient has a more transplant, means has a better outcome after transplant compared to the patient undergoing the LVP. Now, the newer molecule like midodrine, the midodrine is an alpha-adrenergic agonist used in the cirrhotic patient with the ascites. It increases the arterial blood volume by causing the splenic vasoconstriction. Initial stage I have already told. All the mechanism depends on the either you have to do the vasoconstriction, splenic vasoconstriction by anyhow to improve the renal perfusion or glomerular filtration, and ASLD guideline recommend the midodrine for the refractory ascites. Okay. Clonidine. Clonidine is an alpha-2 adrenergic agonist. Its effects are similar to those of midodrine, but clonidine is leading to the hypotension. So you can use this patient, particularly in the young patient with the high blood pressure due to the high sympathetic nervous system activity. So very few patients, but you can use it. Now you see the effect of the midodrine in the refractory ascites. It decreases the weight, increases the mean arterial pressure, increases the urinary volume, decreases the creatinine, increases the sodium excretion, decreases the plasma renin, decreases the plasma aldosterone. But whatever effect you are seeing in the chart, you may not be able to replicate the same effect in your what we call the refractory ascites patient, or either there is a complete response. If you see the number of the complete response is around 2, 5 or 5. So most of you will get around a partial response. Complete response is defined by the elimination of ascites. Partial response is not requiring paracentesis. Absence of response was defined as a persistence ascites despite of the midodrine. So how will you start the midodrine? Its starting dose should be 5 milligram orally 3 times a day. Sometimes there you are very cautious in starting is 2.5 milligram 3 times a day, and increment is every 2.5 milligram every 24 hourly. Maximum you can use is 17.5 milligram, means around 50 to 55 milligram of midodrine over 24 hours. And the goal should achieve a mean arterial blood pressure around mean arterial pressure is around 82 millimeter of Hg, or you have to increase your blood pressure by 10 to 15 millimeter of mercury from the baseline. But it should be taken during the day, and its interval should be 3 hourly or 4 hourly, and you should avoid before at least 4 hours before going to bed to avoid the supine hypertension. So there are also drug-drug interaction with midodrine. You can have a digoxin toxicity and arrhythmias. You have to avoid this drug with the phenylephrine, ephedrine, thyroid hormones, ergot derivative, and salt-retaining steroid like fludrocortisone. You should avoid MAO inhibitor that lead to the cheese reaction. Alpha blocker can also antagonize the effect and interaction with metformin, daditidine, and antiarrhythmic drug. So useful but not very useful with drug-drug interaction. Midodrine should consider with caution and after proper literature review of the literature. Again, Vaptans, it is a very what we call the lucrative option in form of the cost. It lead to the accuracies, treating the hyponatremia and reducing the fluid overload. Particularly, it is useful in the dilutional hyponatremia. However, in the cirrhotic, the promise is not holds very much true, and having the negative result in the phase 3 study of the Setavaptan was a setback, having a risk, but cost is relatively cheaper than the midodrine. But again, if you see the few papers that have renewed the interest that the pharmacological action of tolvaptan in the patient with the cirrhosis is not as bad as the previously we think, and you have to choose it correctly. Particularly, you have to choose in the patient having the sodium less than 120, and if you start tolvaptan and if sodium is not increasing, then you have to stop it. Otherwise, it may lead to the detrimental effect. And there is also a safety profile because it leads to the increase in the gastrointestinal bleeding, as well as there is an increase of the intracranial hemorrhage has been reported. And uh, sudden increase in the sodium may occurs that may lead to the osmotic demyelination. So this is another potential complication, but not observed in the any trial reported to the date. But you have to frequently check the sodium when you start a Veptan in the cirrhotic. So take your own call on the starting of Veptans or not. This is a newer system which is called the alpha pump system. The cost is around 20 lakhs, difficult availability, and not a proper expert, what we call available in the India at least. And the pump has been created that the ascitic fluid from the peritoneal cavity, just like in figure, directly going to the bladder. It is a battery operated. Okay, but significant reduction in the recurrent paracentesis, and mainly used for the patient who is unsuitable for tips or unwilling for tips, or after tips they have some problem with the tip stent or portal vein thrombosis or cardiac dysfunction, something like that. So though it's a newer system, I think for the practical purpose, we cannot use it very frequently, or I think we require a very cooperative patient, very educated patient, and very rich patient to implant such type of device. Now, this is a one response guided regime of the large ascites. This is a trial done by Virendra Singh and Dr. Gaurav Pandey. They have started furosemide 2 milligram per hour infusion along with the albumin 40 milligram per day, mixed furosemide plus albumin, and 10 ml per hour they have started. So 2 gram per hour albumin is going on, 2 milligram per hour Lasix is going, furosemide is going on. They monitor the sodium, and target is sodium is more than 80 millimole per day. If it is 80 millimole per day, then you have to increase the furosemide till 12 hour till 48 hour if you have sodium less than 80 millimole per day. Okay, so if it is still less than 80 millimole per day at 48 hours, start teliprecin 2 milligram every 24 hourly. Again, monitor sodium. It is still less than 80, increase teliprecin and alternatively furosemide. And maximum use of dose teliprecin is around, I think, around 12 milligram, and furosemide is 12 milligram per hour. So this you can use in a very refractory ascites under strict guidance, but this is only trial published by or protocol used by Dr. Virender Singh, and he is better judged to decide on the large implementation. Uh, so when you have a ascites, first go for salt restriction, ask for the proper dietitian, compliance check, start diuretics, spironolactone plus loop diuretics, a frequent follow-up, look for the side effect, look for the weight and urine output. If not there, increase the dose of diuretic. If not there, if the patient has a high requirement of diuretic, explain about the future risk of transplantation, tips, regular albumin infusion, recheck salt compliances, and sometimes large volume paracentesis if tips is not available, or contraindicated if tips is available, go for tips. Repeated taps if no other option. Alpha pump if you are and patients are very fortunate. So thank you very much. Once again, I sorry to sudden change of the time of the lecture because I have to go somewhere and it is not available. So any question, you can just type in the chat box, and I can answer it right now. Or as I said, because this time is the busy schedule. Most of you are doing a practice or doing work in the ward, resident doctor. So I will send you a recording, and if any question, you can WhatsApp me also. I will send my WhatsApp number also. Anything from your side. So thank you very much, and again we will come after 15 days with some lecture on the liver disease. and at that time we are hoping to maintain the schedule. Thank you.